As you know, in the previous class, we will discussing about the water and electrolyte balance. In the water and electrolyte balance, firstly, we discussing about the functions of the water fluid inside the body. That I already tell you that in our body, several metabolic pathways are pursued by different enzymes. Okay? And these enzymes are working in the presence of water and we called as hydrolytic enzymes. Okay? So most of the biochemical function, most of the relative functions of water we already discussed in the previous class. Okay? We also discussed about the electrolytes. What is electrolyte? That is the salt which when uh, taking by the diet inside the body and it is dissociated into ions. This is called electrolytes like NaCl and other things. Okay. Now today we are going to discuss about the clinical part of this electrolyte imbalance. Understand? Okay. So before we discuss about the clinical part, first of all, you have to know about what the meaning of ICF, that is extracellular fluid, ECF, interstitial cellular fluids. Okay. Why I am telling these words to you? Because you already know that these salt are perform the basic the process we call it osmoregulation. Osmolarity. Do you know the meaning of osmolarity? What is osmol? No. Osmol is defined as the solute is present in the solution in the form of salt. Okay? So basically these all salt perform the basic function that is called osmoregulation. And for this osmoregulation, there are different mechanisms are present which are performing this osmoregulation process. Okay, so basically we are going to discuss about the balance of the electrolyte. That means either it is hypertonic, hypotonic, isotonic. You already know about this term because it's mainly discussed in the transport mechanism process. Okay, so the presence of sodium, presence of chloride, presence of potassium inside the cell, making concentrations of the salt inside the cell. If these salts become flow out from the cell become going to hypoosmosis process, hypotonic process. Okay, so most of the clinical part is associated with it, like in the presence of how these electrolytes being lost by the body, such like in the case of dehydration, in the case of vomiting, why the person feel laziness, how can we treat it, and what is the main cause behind it, that we already discussed. We all of this discussed today. Okay. So I think today we complete this topic because this topic is not much more time to discuss about all this. This some introduction about this. You have to see the slide, look at the slide, what we discussed before and what we are going to discuss in this class. Water we already discussed, there is a source of the water, how it is maintained, homeostasis levels. Homeostasis levels means in the ratio of intake and output of water is become in equilibrium. Okay? The balance is called homeostasis. There are several biochemical factors which can play a role to maintain this balance. Now we discuss one by one. Intracellular fluid, interstitial fluids. There is some terms you understand. What is the meaning of intercellular fluids? The fluid which is present inside the cell, and the fluid which is present outside the cell but at the adjunction of the two cells. That is called interstitial fluid. Why I am telling you, there is a one also term, it is called extracellular fluids. When we talk about the extracellular fluid, it is mainly transcellular fluids, it is interstitial fluids, okay? And when I will talk about the intercellular fluid, it is the fluid which is present inside the cell. And it's not only contain the fluid. Fluid means it contain also a salt. So to maintain this osmoregulation, you already know there is ion exchange transport system is occur. To maintain this fluid retention, to maintain this balance, to maintain this homeostasis, what is required here? Proper balancing of the side inside the cell and interstitial fluid. And all the major clinical problems are associated with it. We already discussed all of the things that how the body maintain the water electrolyte balance. Okay. Number of cation, number of anions, that ECF, extracellular fluid contains sodium 140 milliequilibrium per liter. Anions, it contains 103 milliequilibrium per liter. Same as in the case of potassium, calcium, magnesium. Carbonates, bicarbonates, sulfates. Okay. So the ratio is maintained. That means the ratio of positive cations and negative cations are maintained. Now we discuss here. Yes, that is the word. The number of moles per liter of solution and osmolality is the number of moles per kg of solvent. Osmolality. To maintain osmolality means the number of moles per kg of solvent. You have to know the terms, because when we discuss about the clinical part, there is several times the use of terms osmoregulation. You have to understand that here we are talking about the solvent which is present in the solution. Okay. Now, we already discussed all of these things, so I have not repeated it. Okay. So, fluid exchange, all the things yes. Now that is the part to being going to be discussed. That is biochemical factor which regulating water and electrolyte balance. I will give you some introduction that several biochemical factors like ADH, antidiuretic hormone, vasopressin hormone. Okay, it maintains the water level through the kidney. There is a one hormone called anti-natriuretic factor, ENF factor, which is released by cardiac muscles. It is also helpful to maintain the electrolyte balance, because you know the presence of sodium and chloride also maintain the blood pressure, the pulse rates of the body. If we take high concentration of salts, they ultimately increase the blood pressure also. Okay. Now, the first one is neural mechanism, thrust mechanism. What is the meaning of that? That is the thrust center which is present at the hypothalamus of the brain. When a person feel dryness, when a person feel thirst, okay, then it take the water to at the time of thirsting. So what is the meaning of that? It is ultimately when we feel deficit of water inside the body, that it is maintained by the thrust, hypothalamus thrust center. Okay. Now second one is antidiuretic hormone, vasopressin. You already know when there is a disturbance of the secretion of this ADH hormone, which disease we cause? Yes, diabetes insipidus. Diabetes insipidus. So ultimately, diabetes insipidus is a several other types of diabetes which is related with antidiuretic hormone. Now the second one is renin-angiotensin systems. You already know renin is secreted by basically kidney. And this angiotensin first is converted into angiotensin second by enzymatic factor. And it is a factor which regulates the blood pressure also inside the body. Okay? Aldosterone, arterial natriuretic peptides and kinins. Now we see all the factor one by one, and I think you all of the make the notes if something you feel important. Like when the body of water is lower due to low intake of fluid or body fluid lost through obligatory losses, urine and feces. So ultimately, in the case of loose motion, in the case of diarrhea, there is a excessive loss of fluid. So we already discussed that to maintain this balance, body take fluid through the dietary method, through the outside, to maintain the fluid balance. Okay. In the case of no intake of fluid, when a person have severe illness, when the person are already admitted in the IPD, in a severe condition. Okay. So the person feel thirst and they take the water to maintain the balance. This lead to decrease in the volume of body fluid with respect to solute and rise the osmotic pressure. So ultimately here what we are talking about, it is just like a polythene bag which contain a water and the salts. If the water is loses, salt concentration become increases. May I right or wrong? Yes. No, that is not loss of water. This is only a loss of water. Understand? Now you see that it contains intracellular fluids, water losses from extracellular fluid compartments. There is a ICF intercellular fluids, interstitial fluids and extracellular fluids. Water losses from extracellular fluid compartment, solute concentration increases in extracellular fluid compartment. So the ADH is also mainly perform the function of reabsorption in the kidney. Now role of antidiuretic, when the body water is depleted, ADH exert antidiuretic effects. ADH affects renal tubules and urine output will be lower, urine concentration will be increased and body water will be maintained. So ultimately what the EDH is doing here, it's maintained. How it is maintained? It decreases the rate of reabsorption. Okay, ADH. Now the third system is renin-angiotensin mechanism. It mainly helpful in the blood flow. That is, renin-angiotensin systems, blood flow is, volume is low, blood pressure is low. So ultimately renin-angiotensin are helpful to maintain the blood pressure of the body, and it is mainly secreted by kidney, liver and lungs. Okay. Same is in the case of like insulin. Insulin is secreted as proinsulin and it is converted into insulin. Okay, in the activated form. Same as angiotensin is converted into angiotensin second. This is a functional form. Okay. So what is happening here? The angiotensin is basically synthesized by the liver and its functions on also, and it is converted into angiotensin second. Okay. And these perform several functions like vasoconstriction, first function. Due to this, it increases the blood pressure. Okay. And these angiotensin stimulate the secretion of aldosterone through the adrenal cortex. In the adrenal cortex, these aldosterone secreted by zona medulla or zona. Revise all the topic. It is from physiology, na? Huh? In the adrenal gland, these are secreted by which portion of the gland? Zona granulosa. So ultimately increase water reabsorption and decrease urine volume, increase blood pressure. So ultimately the function of angiotensin is what? It increase water reabsorption, decrease urine volume, increase blood pressure. Okay? So you will write this point in your copy that like that angiotensin first function is what? Increase water reabsorption, decrease urine volume, increase blood pressure. Okay? Now it is released by the kidney in response to decreased blood volume. Renus causes angiotensinogen, plasma protein formed in the liver to split and produce angiotensin first. And it is converted into angiotensin second, which is a functional form. So they ultimately release aldosterone, or which maintain the blood pressure by vasoconstriction process. So ultimately we see decreased blood pressure, now we see the second factor. Now you see this particular figure, we understand that these are secreted. Angiotensin is basically secreted by the liver and it is converted into angiotensin first and through angiotensin second by the converting enzyme. Okay, and this can act on the kidney portion to maintain the water electrolytes balance through the tubular reabsorption of sodiums and water. So ultimately it is an important factor. You all read this in detail if you want. The one of the important factor. Now role of aldosterone. It is a steroid hormone which is secreted by zona glomerulus of adrenal cortex. Okay. So at least these questions are generally asked in your viva to analyze you what you are studying in the whole year. Generally it may be asked from which portion of the adrenal gland this aldosterone is secreted. It is from zona glomerulus. It is the most important factor on mineral metabolism. So when we discussing about the mineral metabolism, we discuss all the factors. So it is related with the renin-angiotensin system. You understand? Angiotensin second is stimulate the secretion of aldosterone, which causes vasoconstrictions and maintain the blood pressure. Now I finished this topic. Now factor affecting aldosterone secretions. There are some factors. I'm not discussing now. This is the fixed factor. Arterial natriuretic peptides or factor ANP or ANF. Anyone can tell me from which portion it is secreted? Huh? Yes, it is from hematocrit. I am not expecting the answer from the first line of this class. I am expecting the answer from the last bench also. Rakesh. Try to give the answer. Okay, be alert in the class. If I will ask the question from which portion it is secreted, if say from dimetrium, you will give the answer. Okay. So what is the role of this to maintain the water balance It is a cardiac hormone which is secreted by the right atrium of the heart, and it is a polypeptide hormone. The function of this hormone is released to response of blood pressure. It is mainly maintain the blood flow. It mainly opposes the renin-angiotensin-aldosterone system due to increased blood volume. So what is happening is that in the renin-angiotensin-aldosterone systems, it's mainly helpful to secrete aldosterone. What the aldosterone do? It causes vasoconstriction. So ultimately it will fall down the blood pressure. But in response to ANP and ANF, it increases the blood pressure. That's why we call as this can opposes the angiotensin aldosterone systems. Okay. Now ANP suppress renal level, decrease the release of aldosterone, decrease ADH release, and some other function stimulate excretion of sodium and water, reduce water vascular resistance by causing vasodilation. There are the two processes. The first one is vasoconstriction, second one is vasodilation. Vasoconstriction is mainly processed by aldosterone, that is steroid hormone, and vasodilation is caused by ANF, arterial neurotrophic peptide factors. Okay, so both are opposing each other. Functionally it is antagonist. Okay. Now role of attenuating factor ANP increases the urinary excretion of sodium and regulate the electrolyte balance. Can anyone tell me how it is excrete the sodium? No. If we increase the blood flow, if the blood flow is increases, water excrete करेगा. My question is simply, it is urinary excretion of sodium. It is excrete along with the water. Okay. So you have to correlate this that there is increase of glomerular filtration rate because plasma blood flow filtration is increases. Because what is GFR? Glomerulus filtration rate. That is blood plasma is filtrated through the glomerulus per minute. If the blood flow is increases, ultimately reabsorption rate is increases. So more and more sodium is excreted out. So it is related with the GFR. Okay. Now role of kinins. Kinins are proteins in the blood. Kinins causes inflammation and affect blood pressure, especially lower the blood pressure. You have to write this as point. Kinin increase salt and water excretions. Okay. So these all are the factors which can maintain the electrolyte balance and function different function. The first factor is, tell me one by one. First factor is, yes, first factor is neural response. That is thrust center in the hypothalamus which regulate the water balancing, homeostasis of water. Second one is, yes, ADH, antidiuretic hormone, vasopressin hormone, which slow down the rate of reabsorption. Third one is, yes, renin-angiotensin. Fourth one is ANF, anti-natriuretic factor. Fifth one is kinin. Okay. Now osmolality of the solution. You have to understand all these terms. Isotonic solution, same concentration of solutes and plasma. You have to know the solution. What is the meaning of isotonic solution? Students, now your question comes in your mind. Any question comes in the university exam from this topic? Yes, it mainly comes in justification questions. 5 marks. जो क्वेश्चन आए थे ना इन द एग्जाम, उसमें आता है ये क्वेश्चन. ठीक है. आइसोटोनिक सॉल्यूशन, सेम कंसंट्रेशन ऑफ सॉल्यूट्स एंड प्लाज्मा. hypertonic solutions, greater concentration of solutes. Then plasma, hypertonic solution, lesser concentration of solutes than plasma. It is correlate with the plasma. Okay. Now example of isotonic solution, 0.9% sodium chloride solution, that is NaCl. Ringer solution typically contains sodium chloride, potassium chloride, calcium chloride, sodium bicarbonate. Lactate ringer solution contain additionally lactate. Can you see these types of solution where it is used? Ringer lactate, 0% for normal saline in the IPD. Yes, when the patient comes in highly severe state, we provide all these solutions intravenously, IV fluid, in the form of IV fluid to maintain the health status of the patient. Ringer lactate. You have to know at least the meaning of what is the meaning of ringer solution. That it contains sodium chloride, potassium chloride, calcium chloride, sodium bicarbonate, 0.9% sodium chloride solution. These are all isotonic solution. What is the meaning of isotonic solution? What is the meaning of isotonic? Same concentration of solute and plasma. So to maintain isotonic condition, we use ringer lactate solution, normal saline. Okay. Now you see the figure, you understand cell in isotonic solution, it is in normal shape, but when we provide cell in hypotonic solution, that is 5% dextrose and water, 0.45% sodium chloride, 0.33 sodium chloride solution, it become more exploit. It is in swell because it the process of which one? Yes, and osmosis. Now hypertonic solution is 3% sodium chloride, 5% sodium chloride, whole blood, albumin, concentration of dextrose which is more than 10%, not less. So the cell become rupture in the condition of hypertonic solutions. So what is here? There is a several property. Endoosmosis, exoosmosis are occur in different solution condition. Okay. Now, what condition lead to water and electrolyte imbalance? We are discussing here the clinical condition which is associated with that condition. The first one is water intake, factor involved in water and electrolyte balance. Water intake. In many of the conditions, the person denied to take water, such like in the case of severe illness, in the case of coma. Okay, there are some conditions like in the pregnancy and other conditions, person denied to take water orally, so it disturbs the water balance. Okay, there is deficient condition of the water. The first factor is that. Second one is electrolyte intake. Now hypothalamus, pituitary gland, kidney, liver, lungs, and the glands, all these maintain what? Water and electrolyte balance. If all these organs are discomfort or disoriented to do their functions, so ultimately it mismanage the electrolyte and water balance. Now regulation of the water fluid, you have to understand this chart. Regulation of water fluid, it is hypervolemia, excessive fluid, deficient fluid volume, ADH release inhibited, aldosterone. We understand all these topics in detail. What is the role of ADH, what is the role of aldosterone, thrust inhibited. Okay, so ultimately these are the factors which can only maintain the balance of the water. So any defect in the ozone associated to factor regulating water and electrolyte balance may lead to water and electrolyte imbalance. So anything that alters the concentration of the electrolyte alters the concentration of water and vice versa. Now the condition which can causes water and electrolyte imbalances. The clinical condition which that. The first one is dehydration, second one is overhydrations. Dehydration is loss of water through the body in the case of vomiting or severe diarrhea condition. Okay. Now dehydration is the condition of water imbalance that is mainly characterized by disturbance of water and electrolyte balance. Okay. So question is that how you feel person feeling dehydrated? How the person you will show dehydrated? Yes, dryness of mouth and pharynx. Okay, first, second, shrunken of the eyeballs. Third, dryness of the skin patches. Dryness of the skin patches. Okay. It is a dehydrated body, output of water exceed intake, reduction of the water flow and the normal one. Now these are the basic causes. No ingestion of water. There are several conditions in which person deny to take the water. Excessive loss of water, body fluids. It is a clinical condition like in the case of diarrhea, vomiting, in the infection of GI tract. Okay. So all these causes the dehydration condition. Now feature of dehydration, water deficiency condition, low body water, low blood volume, disturbance in body electrolytes. Types of dehydration, you have to understand the types of dehydration. Primary dehydration, primary, secondary, mixed type dehydration. Okay. So first one is primary. When we talk about the primary dehydration, it only means there is a loss of water. Loss of water in the case of diarrhea. Okay, so it is called primary dehydration. In the secondary dehydration, there is a loss of water plus electrolyte. The example of vomiting. In the case of severe vomiting. Mixed type dehydration, pure salt depletion due to both water and salt depletion. Now we see this. What is the cause of primary dehydration? Primary dehydration is what? It is a deficient condition of the water inside the body. It's mainly by weak and very ill patient unable to ingest water, mental patient who refuses to drink water, in coma conditions, person lost in desert and shipwrecked. These all are the condition. What is the meaning of shipwrecked? किसी का वाला the ship become कहीं अच्छे how can I express जहाज का कहीं फंस जाना, that is only a shipwreckage. ठीक है. So these are ultimately all these factor what it causes water imbalance, pure water imbalance. That's why it is called primary dehydration. Okay. Now defect in hypothalamus, person not feeling thirsty, patient with renal tubular disorder, diabetes insipidus, ADH insufficiency. Biochemical alteration, pure water depletion occur almost always because lack of water intake, excessive losses from the body. Body water store get depleted. Ultimately, if a person having these symptoms, very big illness or a defect in hypothalamus, but the obligatory process are continuously occur, person are regularly going for urination, for fecal excretions, so there is a loss of water, which causes deficient condition of the water inside the body. Okay. So the volume of ICF is maintained almost normal in this condition, and intercellular fluid which grossly reduces in the volume causes intercellular dehydrations. So ultimately there is a dehydration which is mainly called intercellular dehydrations. And for generally for the compensated over compensated over this process, we go for taking regular water. We increase the water intake. And ultimately we overcompensate these disorders. Now clinical manifestation: dry tongue and pitchy faces. You have to write down all these clinical symptoms. Due to intense thirst, oliguria, excessive secretion of the urine, we already know, causes a gradual diminution of urine volume. How we manage this? Take water, drink by mouth, by provided IV fluid to correct intercellular dehydration. But in this condition, there is a cause: never give isotonic solutions. Why we not give isotonic solution? Because due to dehydration, intercellular dehydration, the concentration of the salt is already more inside the body. If we provide ringer solution, if we provide isotonic solution, the salt concentration increases. If the salt concentration increases, person becomes hypertensive. Now, mixed type dehydration, water and salt depletion. In the case of severe vomiting, severe diarrhea, both the salt and fluids are excreted out from the body. So deficit of water and electrolyte is present in the case of mixed type dehydration. Okay. Now mixed type dehydration, both low volume of water and electrolyte, volume of fluids in both ICF and ECF is reduced. Patient appear dehydrated and complaints of thirst. Complaint of thirst due to deficit of water and dehydrated. Now feeling of thirst, low BP, increased blood urea, urinary output is diminished. Because diminished means urinary output is less. Why? Because it is dehydrated. It is become a severe condition like in the vomiting. Because what we see, for maintaining water balance, for maintaining homeostatic condition, we intake the water orally and we excrete out the water in the process of urination in fecal excretion. Okay. When we loses the water through clinical condition like vomiting and diarrhea, we deficit the water inside the body. So ultimately urine output also decreases. So there is an imbalance of water. Management, we provide here normal saline solution and 5% dextrose in this ratio, 1:1 proportionate. Okay. Secondary dehydration, ultimately pure salt deficit condition, and the causes are excessive sweating, GIT, loss of fluid during vomiting and diarrhea, continuously aspiration of GI fluids, addition disease, insufficiency of adrenal cortex. Can you tell me what happened in addition disease, insufficiency of adrenal cortex? What happened? Yes, aldosterone concentration is become less. So vasoconstriction process is not proceed out, and ultimately it decrease the concentration of the salt by use of diuretics. Now, we see the series of event of secondary dehydration, how it is causes excessive blood loss, sweating, vomiting and diarrhea. With intake of plain water, decrease sodium concentration of interstitial fluids and plasma, which ultimately cause hyponatremia. You know the meaning of hyponatremia? That is, when the sodium level is low from the normal level, it is called hyponatremia. Okay? Decrease osmolality of the interstitial fluid and plasma. What is osmolality? You already know. Osmosis of water from interstitial fluid and intercellular fluids. Water intoxication, cell swells, convulsions, coma, and possibility of death. So secondary dehydration is a very severe condition of the patient when the patient loses water and electrolytes. Okay. So ultimately there is a convulsions, coma, because it is neural symptomatic arises because they are for function of the neural and muscular functions. Their muscles cramps are also comes when we have loss amount of sodium and potassium. Muscular cramps, muscular twitchings, okay, tremor and convulsions, okay. So all these clinical symptoms are comes when the person having severe dehydration. So you have to at least write down the symptoms which is comes when there is mixed type of secondary dehydration is occur. So all of you at least write this point. Okay. नोट किया ये, नोट कर लीजिए. सिर्फ ये नोट कर लीजिए, was intoxication. Water intoxications means cell swells. Water retain inside the cell. Okay. Now we see the causes of secondary dehydration. This is absence of thirst, patient hallucination and confusions are common, anorexia and nausea, cramps in thigh, abdominal and respiratory muscles, sunken eye, elastic skin, low BP, decreased GFR and excretions. So all are related with the function of the electrolytes. Okay. So in the secondary dehydrated condition, there is a deficient condition of electrolyte. There is low presence of the salt inside the body, which ultimately causes different functions. Cramps in the thigh, abdominal and respiratory muscles, has hallucination and confusions are common, anorexia and nausea. Okay, so all these symptoms are comes. Now in this condition, we provide the patient isotonic solution of 0.9% NaCl. Okay. Now there are some differences. You already read this from your book. Generally, all are given. That is caused by pure water depletion, pure salt depletion, dysphagia patient with excessive sweating, vomiting, diarrhea, no electrolyte replenished, feel thirst, cramps. So generally what you see, the first slide, the first here causes the main cause of primary and secondary. Second is person feeling what kind of condition person feel in both the condition, and lastly the which symptoms arises in the cause of primary dehydration and secondary dehydration. Now we complete this topic. Firstly, hyponatremia, you have to take photo of this slide. Hyponatremia less than 130 millicurium, hypernatremia more than 145, hypokalemia, chloride imbalance, magnesium imbalance. These are the electrolyte imbalances conditions. Okay. Now common symptoms which are arises during imbalance of electrolyte. The first one is edema condition, that is fluid retention inside the cell. Okay. Common condition of edema is inflammation, infection, pregnancy, medications, increase hydrostatic pressure, small blood vessels become leaky and release fluid, all the tissues, venous obstructions, lymphedema, renal failure, lower plasma osmotic pressure, protein loss, liver failure, malnutrition and burns. Because when we see the patient of hypoalbuminemia, in protein energy malnutrition cases, in Kwashiorkor and marasmus, you will see the patient subject child having edema in their feet. Okay, so ultimately the suggestion is what? It maintained the osmotic pressure. Okay, increase capillary membrane permeability, inflammation and sepsis. Types of edema: generalized edema, organ specified edema, ascites, pleural, cerebral. Ascite is related with the liver, pleural is from lungs, and there is for meningitis condition in the case of cerebral edema, cutaneous pitting edema, non-pitting edema. There are several types of edema. Consequences of edema: diabetes insipidus, it is related with the ADH. Addition disease, you know, it is related with the secretion of aldosterone hormone, mineralocorticoid. There are some questions related to the distribution of function, what are in human body, what are electrolyte give in distribution of function related to human body. These are the questions comes. Okay. So over there, thank you about this. If you have any queries, read the topic in detail. If you have any queries regarding this, you will ask to me. Okay? Thank you.
So you did not attend this class. At the top of the spinal cord there are two nuclei, nucleus gracilis and nucleus cuneatus. The fibers in the fasciculus gracilis, they end up in the nuclear gracilis, and fibers in the fasciculus cuneatus, they end in the nucleus cuneatus. Then actually, for the sake of simplicity, the ascending tracts, the tracts which carry sensations going from lower to upwards towards the brain, those are shown in the left hemi or left half of the picture, and downward fibers called the descending tracts will be shown in the right side of the picture. So 1, 2, you can call it 1. You can call it 2, 3, 4. 3, 4, numbering are 3. 3, 4, yes. 5, 6. 5, 6. So 1 is fasciculus gracilis, 2 is fasciculus cuneatus, 3, 4, 5, 6. If you know these 6 ascending tracts, it is spinocerebellar tract. 3 is dorsal spinocerebellar tract. From spinal cord, fibers go to the cerebellum. 4 is ventral spinocerebellar tract. So 3 is dorsal ventral spinocerebellar tract. Okay. Five is anterior spinothalamic tract. क्यों कुछ बोलছো? কি বলছো? Dorsal spino CE লিখেছি cerebellar tract. Ventral spinocerebellar tract. Okay. Dorsal spinocerebellar tract, ventral spinocerebellar tract. আর 5 হচ্ছে anterior spinothalamic tract, anterior spinothalamic tract. আর 6 নয়, lateral spinothalamic tract. হয়ে গেল 6টা ascending tract. Fasciculus gracilis, fasciculus cuneatus, dorsal side spinocerebellar tract, ventral spinocerebellar tract, anterior spinothalamic tract, lateral spinothalamic tract. Anterior spinothalamic tract উপর দিকে যেগুলি আছে সব ascending. Ascending মানে সব sensory. Anterior carries all the soft sensations. That means touch, crude touch, etc. Fasciculus gracilis and fasciculus cuneatus, they carry, also called dorsal tract together. They carry all very fine sensations like fine touch, tactile discrimination to differentiate between touch. দুটো আঙুল ঠেকাচ্ছি কতটা দূরে সেটা বলবার ক্ষমতা, that is tactile discrimination. So tactile discrimination is the ability to differentiate between the distance between two touching points. Suppose you take the divider of a compass box. Take the divider of a compass box and see. Put it like this on the screen. And ask 1 or 2. If he says 1, that means don't laugh. It will be like this. If you close your eyes, it will be like this. Even 2 centimeter, 4 centimeter, only after 5 or 6 centimeter, he can say 2. Otherwise, he will feel it is 1 only. So, tactile discrimination is a very delicate sensation, not very crude. So, anybody and everybody every time can say that. It is not that. So, tactile discrimination, very fine touch, like the touch of a cotton wool. Light touch of a cotton wool. That is fine touch. And a crude touch. This fine touch, pressure sensation, definite pressure. He will say, I will feel pressure, not touch. And joint sensations coming from joint. Is the hand flexed or extended? That is easy. Is the finger flexed or extended? Is the distal joint, distal interphalangeal joint, flexed or extended? These proprioceptors means sensations coming from joint sensations. Also pressure sensation. These all are fine sensations and they are carried by the dorsal tract. Tractus gracilis or fasciculus gracilis and tractus cuneatus or fasciculus cuneatus. Anterior spinothalamic tract, crude touch. Lateral spinothalamic tract, that is also crude touch, but mostly for pain and temperature, heat, cold, pain. Three very crude sensations which you cannot miss. If there is pain, you will say, oh, it is paining. If you put a hot water, oh, it is hot. If you put rice, it is very cold. So this is by lateral spinothalamic tract. And on the right side, up to 6 we have done. 7, 8. No, this is not 8. This is 7. 8, 9, 10, 11, 12, 13, 14, and this is 15. So start with 7. 7 is rubrospinal tract. Coming from above, on the right side, all descending tracts, that is which are coming from the above. Rubrospinal tract, from where? From the name guess. It is from the red nucleus. Red nucleus. 8, this is the 8. Rubrospinal tract, RUBRO. 8 is medial reticulospinal tract. This is the medial and lateral reticulospinal tract. Yes, I think I have made a mistake. हाँ কি বলছো? হ্যাঁ 9টা medial আর 8টা lateral. Yes. না দাঁড়াও 9 হচ্ছে from the reticular nucleus it is coming. From the reticular nucleus to the spinal. 9 is medial vestibulospinal. All these are medial. 8, 9, 10. 10 is not called medial. It's called anterior corticospinal. Sir? 10 is anterior corticospinal tract. 11 is, as I said, lateral reticulospinal tract. Where is the lateral vestibulospinal tract? If the medial is in 9, medial vestibulospinal tract. Where is the lateral? It is in 13. Lateral vestibulospinal tract. And what is 14? 14 is oligospinal tract. It comes from the olivary nucleus. 15 is lateral corticospinal tract. Oligo from the oligoid nucleus. When you go to the brain, if you have already gone in your anatomy classes, then you will know red nucleus, oligoid nucleus, etc. Oligo spinal cord always ends with spinal because they end up in the spinal cord. So rubrospinal, reticulospinal, vestibulospinal, corticospinal, septospinal, 12 is tectospinal, tectospinal, T-E-C-T-O, vestibulospinal and olivospinal, and 15 is lateral corticospinal tract. We have already come across number 8. Medial, yes, anterior corticospinal tract, that is in number 10. So this is we already talk about this whole thing in our previous class, but because only 7 or 8 students, even today also very few students have come. Now today I was supposed to talk on pathology, some problems of the spinal cord. Problems of the spinal cord is not very few and far between. Don't think that. In these days of automobiles, there are every now and then there is an automobile accident. And if you are in the emergency department of any hospital, you will definitely come across some automobile accident every day. Okay? You will definitely come across some automobile accidents every day. And if this automobile accident is severe, the whole spinal cord may be cut off, just separated, upper part separated from the lower part. Have you understood? So this is called complete transection of the spinal cord. Complete transection of the spinal cord. In our place, there was a doctor, very recently he has died, in 2022. He is actually junior to me, some 4 years junior to me. His father was also a doctor. He got married and nicely he was living. And someday he had some problem with his wife. And he jumped from a height in the house itself. He did not die, but he had a complete transection of the spinal cord. He had such an injury, they had a complete transection. He was immediately, and throughout his life, he was not mostly paraplegic, but the upper two limbs started working. At the beginning, he was quadriplegic. He had quadriplegia. All 4 limbs are paralyzed. This is called quadriplegia. Paraplegia means both lower limbs are paralyzed. And hemiplegia means in one side, both one upper limb and one lower limb of the same side paralyzed. Monoplegia means only one limb paralyzed, which happens in polio. Only one limb paralyzed. Hemiplegia, after a stroke, we get hemiplegia. Left-sided hemiplegia means left upper limb, left lower limb paralyzed. Right-sided hemiplegia, right upper limb, right lower limb paralyzed. See, paralysis has nothing to do with sensation. Sensations may be lost, may not be lost. Paralysis means inability of the muscles to move, inability of the muscles to work. So paralysis may be of several types: quadriplegia or 4 limbs, paraplegia only lower 2 limbs, hemiplegia one-sided 2 limbs, either left or right, and monoplegia only 1 limb, maybe 1 leg, maybe 1 upper limb. So the first thing that happens, it is a very severe type of accident. So first thing what will happen? The patient is not conscious. Total loss of consciousness. So I am talking about complete transection of the spinal cord. Stage 1, stage A, stage of spinal shock. So what are the symptoms? Loss of consciousness. See, there has been no injury to the brain, but you do not know whether there is concomitant injury to the brain also. But in a pure transection of the spinal cord, there will not be injury elsewhere. But still, there will be loss of consciousness. Then total loss of muscle tone. Loss of muscle tone. All the muscle tones. You know what is muscle tone? You know what is muscle tone? Yes, all muscles, all skeletal muscles in our body, all skeletal muscles in our body are all the time in a partially contracted state. So some tone is always there, whether it is working or not working. And this is called muscle tone, that partially contracted state. Complete paralysis of muscles. Complete paralysis of muscles. Loss of reflexes. You try the knee jerk, ankle jerk, abdominal jerk, this jerk, that jerk. All reflexes are lost. At the beginning, only superficial reflexes, and then the deep reflexes also. So complete loss of reflexes. Very low blood pressure. The blood pressure is very low. There are various factors, but the most important factor, neurologically speaking, you may say the patient will have injury to the, it cannot be that a complete transection of the spinal cord and nowhere in the skin there is any lesion, no bleeding, it cannot happen. Patient must be having the bleeding either internal or external or both. And that will cause, if that bleeding itself will cause hypotension. So blood pressure will be very low, sometimes SBP as low as 40 millimeter mercury. Systolic blood pressure may be 40 millimeter of mercury. That also you will have to be very cautious, and you will, with full concentration you can only hear the tap sound at the 40 millimeter of mercury level. So these are all. But what is the neurological cause? Just now I was telling, neurologically speaking, the main cause is that pressurizing effects from the brain, BMC. Ah. Yes, that will be cut off. So there will be no venous tone, and because no arteriolar tone, no arteriolar contraction, so there will be low BP, very low BP. And this stage lasts for not small time, 2 to 3 weeks. During this period, patients' families will keep coming to you every day. Not every day, every hour. Doctor, how do you find? Will the patient survive? And we will have to say, sometimes I have found that doctors have a way of escaping. We cannot say anything before for 72 hours. And the patients are very happy because this is a very common saying by the house physicians or house surgeons. Residents, nowadays we call them residents. So they will say, before 72 hours, but it is not 72 hours. It is 24 into 14, 2 weeks. It may be even 3 weeks. So this time you will have a very bad time. Not only the patient, not only the patient's family, but also you. You cannot say. But you can only say, see, I have seen and I have read that these patients in the stage of spinal shock, this stage lasts even up to 3 weeks. So better not 72 hours, 3 days, but you have to wait for 3 weeks. As long as the patient is respiring, his heart is pumping, we will say the patient is alive. So you will have to wait to see what happens. And what is the cause of this stage? The causes are, number one is loss of all descending motor impulses coming from above, from the different nucleus of the brain. All the stimulating impulses, motor impulses coming through the descending tracts, they are lost. Because they are lost, so in between the spinal cord, the injury is here. So in upper and in lower, all these places, what will happen is, particularly where the injury has occurred, below that, the interneurons, they will keep, usually they send inhibitory impulses. So their inhibitory impulses will be activated. So more inhibitory impulses, that will cause more loss of tone, more loss of reflexes, more paralysis, more loss of muscle contracting ability, more loss of blood, lowering of blood pressure, etc., etc. More sensory loss also, along with motor loss. So this will be there. Now after this, recovery will start. How the recovery will start? That is, sprouting collaterals. The nerve endings, by the use of the nerve growth factor and body's other abilities to regrow, some nerve fibers will be created from the cut ends of the nerves, the spinal cord, and come down and join with the upper cut end of the lower part of the spinal cord. Spinal cord is cut off here. Here is the injury. And some nerve fibers will grow. These are called collaterals. and they will produce some connection. So some impulses, descending impulses will come beyond the carotid to the lower end of the spinal cord. Now the second stage will come. And there is another called denervation hypersensitivity. When a nerve is cut off, that place is sometimes becomes hypersensitive. That means their ability to catch up sensation is increased. To produce an action potential is increased after a cut injury. So this is called denervation hypersensitivity. So what are the two main mechanisms of recovery? Number in two simple words. One is sprouting collaterals. Collaterals are sprouted. New collaterals are created. And denervation hypersensitivity. Now the second stage, stage B. Hypersensitivity. আচ্ছা আরে ঘড়িটা ফাস্ট আছে বি না তার থেকে ফুটবল খেলবে এখন তাই তো না তার থেকে 10 মিনিট নিলাম একটু স্টেজ অফ রিফ্লেক্স অ্যাক্টিভিটি ফার্স্ট স্টেজ ওয়াজ স্টেজ অফ spinal shock. Second হচ্ছে stage of reflex activity. ঠিক আছে এই স্টেজে কি নাম্বার 1 muscle tone reappears. Number 2 muscles regain strength. লিখে ফেলো number 1 muscles tone reappears. Number 2 muscles regain strength. Number 3 reflexes come back. First to reappear is flexor reflexes, then extensor. Number 4 BP begins to rise. Number 5 stage of paraplegia. Upper limbs become active, lower limbs are not working. This is called the stage of paraplegia. In most cases, the stage of paraplegia remains throughout life. Number 6 deep reflexes appear. Tendon reflexes, etc. And number 7, mass reflex appears. Mass reflex appears. So number 1, muscle tone reappears. Number 2, muscles regain strength. Number 3, reflexes come back. Number 4, BP begins to rise. Number 5, stage of paraplegia in flexion. Paraplegia but in flexion, not in extension. The legs will remain flexed. I cannot do it when I am standing. When I lie down, I can sit. So both the knee joints and all other joints, they will be in flexion, in a stage of flexion. Because it is the flexion that appears first, then the extensors. Then deep reflexes reappear. Now is the seventh point was I told mass reflex appear. What is this mass reflex? It is not a normal thing. It is only in those patients we see mass reflex. That you stimulate in one place but the results is in many places. What is the place where you stimulate? You stimulate the upper part of the inner side of the thigh, medial aspect of the thigh. You pinch there. Chimti kata jorse. If you pinch on the upper part of the inner side of the thigh, there will be exaggerated flexion of the limbs. একটা যদি কিছু করে ধাক্কা মার কি হবে? হাতটা এরকম তুলে নি। হাতে যদি কিছু হয়, হাতটা এরকম করি। তাই তো? সেখানে এটা হবে inappropriate flexion, exaggerated flexion of the limbs. Not only that limb, but in all other limbs. Exaggerated flexion in all limbs. B. Contraction of abdominal muscles. The abdominal muscles will contract. You can see the abdominal muscles will shrink. Then evacuation of bladder and bowel. পায়খানা করে ফেলবে, পেচ্ছাপ করে ফেলবে। চিমটি কেটেছে এখানে, সে ভালো পায়খানা করে দিল, পেচ্ছাপ করে দিল। Evacuation of bladder and bowels. Number D, sweating. There will be excessive sweating. If you pinch on the medial aspect of the upper thigh, there will be sweating. And number E, BP will be increased. The blood pressure will increase. So this is the second stage. Third stage is stage of, not in everybody, only those poor fellows it happens, stage of reflex failure. Why this happens and how this happens? Usually these patients lie down for a long time, say 2 weeks or 3 weeks, cannot move. So firstly there will be bed sores. Secondly there will be infection, infected bed sore. Thirdly there will be pneumonia, pneumonitis, UTI, urinary tract infection or urinary bladder infection. All these infections will come. This will lead to toxemia. Infection will, the bacteria will travel and the bacterial toxins will travel throughout the body. So bacteria will come in the blood, leading to toxemia. When the toxemia comes into play, then thresholds of reflexes are elevated. The reflexes, so reflexes will not occur. Reflexes will disappear. Reflex failure. So all nervous mechanisms which work through reflexes, there will be failure there. The result is even the cardiac reflexes, bringing back the blood pressure, respiratory reflexes, isn't it? When the respiration is dilatation, contraction, expansion, compression of the lungs, all these things occur in reflex ways. So they will not occur. The result is death. So infection, toxemia, reduced threshold of reflexes, elevated thresholds of reflexes, loss of reflexes, reflex failure, neural failure, death. A common complications in complete transection of pinor, what are the things that commonly happen? Already we said bed sore, already we said infection. Number 3 is hypercalcemia, because the person is lying in a, not moving. Even the muscles are not moving. They are not walking, forget about that. Even their muscles are not moving. So result is, from the bone, there will be mobilization of calcium. So there will be hypercalcemia. So because of hypercalcemia, there will be renal stones. There will be UTI, urinary tract infections. And lastly, the patient will enter into the stage of reflex failure and death. Finished. Patient is dead. But if you take care, there will not be much of the bed sores, infections and all these things. Then the patient will live normal. This patient in my neighborhood, he was about more than 60 years, some 61 or 2 years he was. But he was sitting, lying, not sitting, only lying in the bed. And he used to see patients also.